right, welcome to Grand Rounds 2024 for August. Today, we're going to learn more about vocal wellness and therapeutic approaches. Rachel Panick has a background in performing arts with both music and theater. Therefore, she enjoys treating performers with concerns regarding vocal health and rehabilitation, in addition to providing education to help build better vocal habits each and every day. Rachel received her Master of Science degree in Speech Language Pathology from Marywood University. She holds her Certificate of Clinical Competence through the American Speech Language Hearing Association and is licensed in the state of Pennsylvania and New Jersey. She currently is certified in Lee Silverman voice therapy, vital stim therapy, myofascial release, and interactive metronome. Rachel has experience in a variety of clinical settings, including working with children in special education, as well as adults in outpatient rehabilitation. She believes in individualized patient care using evidence-based practices and enjoys building rapport with each patient and their loved ones. So please make sure to sign in either using the code and the text or using the QR code. And in a little bit, I'll post that in the chat in case you missed this front slide here. This is our CME information, and the target is all providers. This is our designation statement, and the planners and presenters have nothing to disclose. And these are our learning objectives, and from here on, I will turn it over to Rachel.
Thank you. Hello, everybody. Thank you all so much for showing up. This is a great outcome, so I'm really happy that you are all here. So looking at our course objectives, there's a couple of things that are on here, discussing vocal therapy approaches. We're hitting just 4 main approaches, so just the big 4 here. Differentiating between treatment approaches given different scenarios, how to convey the importance of vocal hygiene to our patients, be able to talk about different treatments confidently, and discriminate between healthy and non-healthy voicing.
For you.
Thank you. Okay, so we're going to do just a brief overview of anatomy. I know it's not our most favorite thing, but it is important, especially when we're trying to convey information to our patients, because a lot of times they're going to ask us, well, why are we doing that? How are we doing it? This is giving a little bit of background. So typically on the very first session, we're talking about diaphragmatic breathing. It is important to get good diaphragmatic breath before you start voicing, because otherwise you won't have enough breath to really support your voice. Your abdominal muscles are included in this, as well as the actual diaphragm muscle, which sits underneath your rib cage. This diaphragm muscle kind of sticks up into our lung area. So in order to have our lungs expand to that 100% capacity, we need to engage our core, engage that diaphragm muscle, and kind of push it out of the way. So as you are demonstrating this to your patients, I want you to think about having your whole abdominal region expand. So as you're breathing, you might have an expansion of your stomach, expansion of your sides, expansion of your back. So like I said, this increases lung efficiency. It gets 100% capacity. And we're also decreasing muscular action in the shoulder and cervical region. So we don't want to add any extra tension or stress to that area. Now, I also explain to patients a lot of the time that breathing alone is just mechanical energy. So you can think of the lungs as being the bellows of your body. Think of a machine that has a bellows that pumps air into it. That is what our lungs are. We are taking this mechanical energy and then turning it into acoustic energy in a little bit. Some other things to keep in mind when you're talking about diaphragmatic breathing is trying different positions too. You can be upright, seated in a regular chair, seated in a reclining chair, or sometimes having patients lay down on like a plinth table or some other therapeutic mat to help get that movement to happen. We oftentimes tell our patients to put a hand on their chest and a hand on their stomach in order to feel that movement. We want to minimize any movement in our chest and really focus on movement in our stomach instead. Once we get that really good air support, the air travels up our trachea and hits the level of the larynx, the level of the vocal folds. So if you remember from your anatomy classes, we can't really even get our vocal folds to open until there are at least 3 to 5 centimeters per water. That's the pressure we're talking about at the subglottic region, that area below the vocal folds. We need enough air to get the vocal folds to blow open. Once they blow open, we get that wave-like movement, anterior to posterior, but also superior to inferior, creating a big wave. Once the air hits the level of the vocal folds, we now have actual acoustic energy. A way to describe that to your patients is we have a sound wave. So we have the wave that is a peak and a valley. You can show them an example of like a guitar string or even a rubber band. Sometimes I use that as an example to show what a sound wave looks like. Once that gets into acoustic energy, then we can start to shape that sound, which brings us to the resonators. So our resonators are structures including the pharynx, which is your throat, the velum, hard palate, tongue, and sinuses. We talk a lot about resonance when we're actually in therapy, so we will get to that in a little bit. But as that acoustic energy or vibration passes through the resonators, the sound can be shaped and have different texture or timbre to it. This is something that I do want you to try if you're able to. Don't be embarrassed. But we're going to start by using an open ah sound really far back in our vocal tract, maybe kind of back in our throat. And I'm going to demonstrate how resonance can change when you're moving your sound forward. Keep in mind that when I do this, I'm using the exact same pitch the entire time. I'm only changing the resonance. So I'll do an example, and then I do want you to try it. Here we go. So just by shaping your throat, the soft palate, hard palate, tongue, and pushing sound into different sinus areas, you're getting a totally different texture of voicing, even though it was the exact same note. Go ahead and try that. I'll give you a few seconds. Thank you, Steve. Perfect, so you're playing with your resonance. It can change, it can shift, and we want it to change and shift. Finally, after your sound is shaped, we then need to shape our speech itself. So that's where the articulation piece comes in. Structures, again, including the velum, hard palate, this time tongue, cheeks, lips, and teeth are also included in that. So this is where we're actually getting the difference between a vowel versus a consonant. We're making the p different than the k and different than the t sound. So that's how we can get our actual speech sounds to happen. I did put in a picture of the vowel quadrilateral because this is super important for voicing, and I want to touch on it just for a moment. When we're talking about voicing, our voices, the integrity of our voices is housed with the vowel sound. So if our patients are struggling with certain vowels, we can kind of take a look at the quadrilateral and figure out where is their sound getting stuck. If you're, again, remember from a phonetics class in grad school, we have our high, low sounds, front versus back sounds. So the E sound, like in beat, has a very different placement than the ah sound, like in the word bought. So I want you to try that too. Go between beat, bought, beat, bought. Try that out. Same thing with bat and boot. Try that, bat, boot. You can feel where that vibration is hitting. That E sound hits really high in your hard palate versus the ah sound is further down in your throat. So you'll notice that a lot of people that have some voice issues or resonance issues might be struggling with those lower sounds like ah and ah because they're naturally lower in the vocal tract. So we have to figure out how we can kind of cheat that vowel to bring it back up. So just a little tangent there. I think it's an important topic to think about. Here's another diagram to take a look at, the power source filter. So this gives a really great overview of the anatomy section that we just talked about. Our lungs are the power supplier. They're what's giving the amount of air and the pressure that we need in order to make voicing happen. Moving from there, you have your larynx, which is the source of your voicing. And then, of course, the pharynx and the mouth being the filter. So that's something that I oftentimes share with patients as well, so they can understand the whole tract from lung all the way to their lips. Okay, so here's where I'm hoping some people will get interactive. What does good vocal hygiene mean to you? Let's hope some people answer.
Feel free to type in your answers.
Oh, yeah. Or you can turn your mic on and talk to me directly. That works too.
Adequate water intake.
Ooh, good one. What else?
Stay hydrated.
100%. I like that that's the first answer. I'll take a sip while you're thinking about that too. All right, we'll move on.
There are some people typing.
Oh, perfect.
Not straining your voice.
Uh-huh, good one. Okay, so good vocal hygiene has a whole bunch of things that goes into it. I believe, yes. So we'll talk about it on this slide before we get to the next one. When you're talking to your patients about good vocal hygiene, you want to hone in on things that they're already doing well and then build upon that. But things including drinking lots of water, not straining your voice, not using your voice when your voice is already weakened. If you're sick, you might want to kind of lay low for a little bit. Making sure you have the right amount of sleep, using good posture, breathing as you're speaking. Those are all things that go into good vocal hygiene. That's not even touching on the diet component as well. So every patient should be educated on what good vocal hygiene looks like, specifically for them. For some people, they're not going to give up their cup of coffee in the morning, and that's okay. We don't have to make them give up that cup of coffee in the morning. What we can suggest, though, is that they add in a whole bottle of water after that cup of coffee. For some people, they're saying, oh, I'm never going to get rid of having a cocktail on a Friday afternoon. That's okay. We're going to, again, give them another strategy to make sure that they're supplementing their negative behavior with a positive behavior. Like it says, please note that this is going to look different for everybody, but try creating a list with patients about their vocal misuses versus abuses to help them identify where they might be doing really well and where they might be falling short. Which brings us right to this next slide here, vocal misuses and abuses. I think it's important to let our patients know that there is a difference between these two terms. A vocal misuse is an actual behavior that we are doing versus an abuse is usually more of an external characteristic or factor. So these are a very brief list, but I kind of hit the big ones on here. Misuses include whispering, emotional outbursts, shouting or yelling, speaking when your vocal folds are weakened, coughing and throat clearing, initiating voice with a hard glottal attack, or cheering. So think of those football fans that scream at the television. Versus the abuses are decreased water intake, increase of alcohol or caffeine, history of smoking, being around dry, dusty environments, increased acidity, poor sleep hygiene, and increased stress. Again, as you go through these lists with your patients, they might be able to say, oh, I don't think I can really change that. That's okay. You're working on making small modifications to get to a better outcome overall. So this study that I read was so interesting because it was specifically about professional voice users, which includes us as therapists. I know myself and some other people on the call have experienced some vocal issues. So this is one that really kind of touched me pretty significantly. According to this review, it was a systematic review, so they looked at a whole bunch of studies. 17% or 4 of the studies in the group linked low awareness of vocal hygiene or insufficient vocal hygiene education to a higher percentage of voice handicap or chronic voice symptoms. So people don't know what they don't know. We tell this all the time. If you're not aware of the things that can harm your voice, you're probably going to have more voice issues in the future. The next point there says 43% or 10 of the studies showed that adequate voice training or vocal hygiene was linked to positive voice outcomes. That's pretty cool. The more you know, the more you can have your voice be better. And then 6 of the studies demonstrated that vocal hygiene education is more effective when it's combined specifically with voice therapy. So that's where we come in as providers. But I think this is super important to share with our teachers, our coaches, our therapists, our singers, anyone who has this vocal professional usage. Okay, enough with that. Let's get into the actual therapy exercises. So this is a video that I show to my patients almost every time we start with straw phonation. I love this video. It has a great visual. So we're going to take a look at this to start.
What we're seeing here is the backside of the larynx. When you vocalize, air comes up from the lungs and the vocal cords start to vibrate. You'll see here that the vocal cords aren't in sync with each other. This asymmetry could be the result of muscles that aren't balanced or coordinated, so you'd hear a periodic break in the sound. What we do want is the vocal cords coming together evenly and symmetrically. When you vocalize into the straw, the air that can't escape through the straw provides pressure backwards to the vocal cords from the other direction. This is represented by the dots you see flowing backwards. That balance between the forward pressure and the backward pressure allows the vocal cords to balance symmetrically and square up. This is when you get the best sound and the most comfortable feeling. Another benefit of the straw is that it actually changes the shape of your pharynx. That's your throat. When you use the straw, it creates more space and length in your vocal tract. More space and length can allow the vocal tract to maximize or boost acoustic energy. Large differences in spaces provides more flexibility and choices for positioning and improves voice qualities with an easier sound. As you do your exercises, you'll eventually want to integrate vowel and consonant sounds with the voice cup. Now that your vocal cords are in the optimal position, they can work together with the rest of the vocal tract to balance your aerodynamic pressures with the acoustic energy, making it so that your vocal cords don't have to work as hard to create sound.
Okay. So with that video, I really like to start with that because sometimes when I tell people, all right, we're going to blow bubbles into a straw, they think I'm absolutely crazy. So that video at least provides the background and the why as to what we're doing. It gives us the physics explanation of how this exercise works. Just a little bit of background about SOVT is that this has been around for years. Starting back in the 1800s. It wasn't actually researched until 1988. However, this has been around for a very long time. It is a long-standing idea, long-standing physics principle. But the main gist of it is that acoustic energy intersects with a narrowing, that's the level of your vocal folds, along the vocal tract. And some of that pressure is directed out of your vocal tract versus the rest of it will go back down to the level of those vocal folds, creating that back pressure and letting the vocal folds relax, low pressure, low impact. To give an analogy to patients, I often describe this as very similar to doing aquatherapy. So if somebody has just gotten a joint replacement, they might end up in aquatherapy as well as PT because it's low impact, low pressure being in the water. This is giving our voice the same kind of environment to work through. The other thing about that video that I wanted to say too is that sometimes people feel the need that they have to buy the straw. They do not have to. We have plenty of materials here that they can absolutely take for free. So please do not make them buy the straw if they don't want to. So when those vocal folds are adducting or coming together, there is not too hard and not too soft pressure happening when you're using the straw and the cup with the bubbles. You can ease that hyperfunction, especially if somebody's really tight and strained and strangled, allowing more of that safe zone to practice those intervals of pitches. You want to create a relaxed and open sensation of the vocal tract. And the other great thing about using a straw and a cup is that you get tactile and visual feedback all at the same time. Again, just going into a little bit of research, not only has this been proven to help objectively, but subjectively as well. This particular article was based on some musical theater students. The objective difference, actual data numbers that they had shown was that semitone ranges increased after completing water-resistant exercises. And 50% of the group felt like they experienced or they perceptually felt a difference in their range after completing the exercises. They also reported an easier way of speaking and a relaxed larynx or throat compared to the control group. After doing these exercises, you should also feel that relaxed, open kind of feeling. Here are some disorders that can benefit from semi-occluded vocal tract exercises: vocal fatigue, muscle tension dysphonia, glottic insufficiency, as we know can be caused by so many different things, vocal fold mismatch, paresis, and presbyphonia. This research study talked about specifically semi-occluded vocal tract exercises and presbyphonia. According to the study in 2020, patients with age-related vocal fold issues were noted to have significantly less noise to harmonic ratio after completing these. This is meaning more clarity of voice, more precision of voice, not having as much of that overtone, undertone sound. Results also found that patients had less of a breathy vocal quality and a lower score on the VHI. So again, we have objective measures having less noise to harmonic ratio, and also the subjective measures that improved, having a better quality and lower VHI scores. All right, so there are so many different methods to accomplish this, and I will be demonstrating them, don't worry. But we could use a cup and a straw, you could do cup only, you could do straw only with various size straws, tongue and lip trills, kazoo, or a Y buzz. You can also use some apps to help track where your vocal ability is going. So here's where we're going to do some demonstration. If you have a cup and a straw and put a little bit of water in that cup, that would be great because you can practice along with me. So I'm going to get my materials here. So usually we walk through a couple of different exercises. I think it's important to note that you do not have to stick to a regimented hierarchy of these exercises. Pick and choose what works best for your patient. You want to make sure that it's something that is feasible for them. Not everybody can do glides right away on day one. That might be something that you have to work up to. But what we're looking for is sound coming through the straw. We are not just humming with a straw in our mouth. The sound actually has to travel through the tube. So I always give people an example of, that's not coming through the straw, but is. So you want to give that demonstration so they can understand what they're supposed to be hearing and what they're feeling. As they do it with the water too, you can explain that they'll see bubbles moving up and down depending on how hard or soft their hum is. So to give you the example, it should sound like this. Hopefully you can all hear it. And that's just sustaining one note. But what you can ask your patients is, where do you feel that buzz? Is it on your lips? Is it in your nose? Is it in your cheeks? Is it on your fingers as you're holding the straw? Or are you feeling it on the cup? That's the kind of tactile feedback that they need in order to understand how this exercise works. So you want to check in with them and make sure that they're feeling the vibration where they should. So you can sustain single notes. You can go up and down into small glides. You can do longer glides. You can even have them work on the coordination between respiratory and phonatory and have them turn their voice on and off. Sometimes I make people do a song like Happy Birthday or Row, Row, Row Your Boat, just to get some variation in pitches. That's one way to attack these. You can also, like I said, use a straw only. I'll use my other straw for an example. Feeling for that forward focus, the buzz going up and down. If that doesn't work, sometimes I use the example of the kazoo. It's still a tube that we're phonating through. This one tends to work the best for people that can't get the straw. Something blocks their ability to get the straw. But if you give them a kazoo, 9 times out of 10, it'll work. So I give an example of air only. I'll put a paper clip on the table, and they have to just use air to blow the paper clip across the table. Nothing happens. The paper clip moves, but no sound is made. The kazoo does not work until you give it sound. And then that way they can hear the difference and see the difference. Oh, that's what I need to do, but using the straw instead. Again, sometimes it takes a little bit to have people buy into this method, but it does work. I'm a firm believer in SOVT. Another thing to let patients know about these exercises is that they're great for rehabilitative, but they're also really good for preventative. So if I know I have a really long day ahead, I'm probably going to do some SOVT warm-ups to get my voice in the right spot. I was doing them on the way here as I was driving. I had my straw and I was doing my warm-ups, knowing that I would have to be talking for the next hour straight. So it's a great way to get yourself warmed up, but it's also a great way to rehab your voice if you are having some soreness or tension or fatigue. Any questions about SOVT? This is like a huge one that we always do in therapy.
Can you remind us what SOVT stands for?
Semi-occluded vocal tract exercises. Any other questions at all? Okay. If somebody says, I don't have a straw, I don't have a cup, great, you do have lips, you can do a lip trill. It's all the same. We're just closing off that vocal tract a little bit. So as long as you're getting that forward focus, you could also do a tongue trill, which I will not demonstrate because I'm very bad at it. But those are all different methods that you can take to get to the same end result. Okay, then we have another big one, vocal function exercises. These were developed by our good friend, Dr. Joseph Stemple. We all know him and love him, dating back to 1994. So thinking about our scope as speech therapists, 1994 was really not that long ago. This is a relatively new exercise when it comes to voicing. We are using this to strengthen and condition and coordinate our vocal folds, as well as finding resonance. So again, you'll see this kind of builds upon, we just did SOVTE, talking about forward focus. Now we're talking about it again. They all go together. Research suggests that vocal function exercises can help improve voicing in children and in aging adults. It can enhance normal voice production and provide preventative care to those with high vocal demand. So again, this is us. This is our teachers, our coaches, our singers. These are great as preventative and rehabilitative, just like the last one. Some disorders that could benefit include muscle tension dysphonia, glottic insufficiency, vocal fold mismatch, vocal fold creasis, and again, presbyphonia. All right, so we're going to get right into the demonstration again. These are the 4 steps of vocal function exercises. We're going to warm up, stretch, contract, and power exercise. If anybody has watched the Dr. Stemple video on MedBridge, he actually makes a comparison to physical therapy. He talks about how the steps or the method we use to get there is a very PT kind of mindset, warming up a muscle, stretching it, contracting it, and then exercising it. So that's what we're doing. We're taking that same concept, but applying it to our voice and the muscles of our larynx. I need a prop for this one. So to start, we're going to do a warm-up. This is going to include a long sustained E sound. Sometimes I have people put an M in front of it for me. And you're going to use either the F above or below middle C, depending on the gender of your patient. Now, if you have patients, non-binary, transgender folks, that's okay. Ask them what note feels more comfortable to them. Even though the standard was put into male, female, we can just ask, hey, what would you prefer? Do you feel like you can go to that F above middle C or below? There is a couple of apps that you can use. My favorite one is called Tuner T1 because it does give multiple octaves that you can play around with as far as notes go. And it also tells you how on or off you are on the note. It is important also to tell your patient, we are not trying to make them singers. We are not trying to make them the best performer they can be. What we're looking for is good vocal clarity, right vocal placement and resonance. So even if they can't hit that F below middle C perfectly, it's okay. That's another thing that Dr. Stemple mentions in his MedBridge video. It's okay if you're not getting the exact note. As long as the quality of the note is there, that's what we're concerned about. So to give an example, make sure my volume's on, I'm going to do the F above middle C. That's my preferred note. And I'm going to do a nasal, forward-focused E sound. E. Trying to find that buzz in my nose. I might find the buzz a little bit in my cheeks. I might find that buzz in hard palate. It's going to be different for everybody. Sometimes, again, I tell people to use an M sound to get into that nasality. Me, in order to find it. Sometimes it's hard to get that nasality. You can give examples like a Fran Drescher. That's a good way to describe it to some people. If that doesn't work, think of another person that has a nasally kind of tone, but usually that can help get them into the right spot. So you're gonna hold out that E for as long as you can, as steady as you can, using a full but gentle vocal quality. So you're not blasting it and you're not whispering it. We wanna find that happy medium. Once they've mastered that, you're gonna go to the stretch component. This is when we are going to be gliding from a low note to a high note using the knoll sound or knoll word. Sometimes people ask me, why do we use knoll? I'll give you two reasons. The N sound at the beginning is nasal, therefore you're automatically going to be set in the right spot, getting the right nasality. And then the OL sound, OL, creates a nice rounded lip, but the L allows your tongue to relax on the bottom of your mouth. So you can really create a nice open space. Think of a megaphone, or you can tell your patients, think of a megaphone, really tight and rounded at the front, but open and relaxed in the back. So you're gonna do a glide using that word. Here we go. Let's hope I don't have a voice break. And then you're gonna make sure that there are no pitch breaks all the way up. Tell them to go very, very slow so they can feel each set of notes gliding on up. The contract is about the same thing, but opposite, high to low. Allowing it to drop into that lower tone. Sometimes knoll is tricky for people, so we can also use whoop as the ascending and as the descending. I'll demonstrate that real quick too. Boom. By using those words, it can help get to kind of blast that voice into action using that W and B sound at the beginning of the words. When they're doing these, you also want to make sure that they're just trying to smooth out any of those breaking points. Another thing that you can talk to them about is register shifting, going from a chest voice to a mixed voice to a head voice. They all kind of sound exactly what they mean. Chest voice meaning that it's coming from your chest. When you're doing a really low, robust sound, no, you can feel vibration in your chest, versus a really high sound, no, you can feel vibration in your head. That mixed area is kind of more of that throaty sound. So as you're gliding between, you can explain to them, it's quite literally traveling from chest to throat to mouth to nose. And then the final step of these exercises is the power exercise, as they call it, where you're going to be pitch matching, still using knoll as the word of choice, and going up a scale from C to G. If you're using, if you're with a male patient, you're going to start C below. And if you're starting on C, on middle C, it'll be a female patient. Again, transgender, non-binary folks, Just ask them where they feel like they're most comfortable in their vocal range. But you're going to hold out each note just like we did for the warm-up, as long as you can, as full as you can, not shouting, not whispering. No. Then you're going to move up. No. No. And keep going through that scale. Again, sometimes people get a little nervous because they say, I'm not a singer. That's okay. I tell them pick any note and move 5 steps up. That works too. Again, we're looking for quality of vocal, the quality of the voice, not necessarily is it the right note or not. Any questions on vocal function exercises? Awesome. Okay, and that brings us to our last big 4 topic, resonant voice therapy. The purpose of this, again, is to refocus the voice away from the larynx and use more of a oral nasal resonant sound. The most common protocols include Stempel's vocal function, like we just talked about, or Abbott's approach, the Lazak-Madsen approach. Both are beautifully done and very easy to learn and administer. The disorders that might benefit would be vocal fatigue, again, muscle tension dysphonia, glottic insufficiency, vocal fold mismatch, and vocal fold paresis. So a lot of these are all kind of overlapping. So first, what you want to do is, again, find the either nasal or oral resonance by using either nasal sounds or open rounded vowel sounds. You can work up a hierarchy starting with words, move into phrases, sentences, and conversation. And this is where I feel like you really want to try to use negative practice. So I'm going to give you a couple of examples of this. When we're talking about nasal sounds, we're probably going to use the M words, the N words, because they start in our nose. So like the word mash or nose. When you're holding out the M or N sound, it's naturally coming through that nasal passageway, bringing it right to the front of your vocal tract. When people are having trouble getting that sound, I tell them to do it ugly or do it really, really poorly. So for example, the word mad, we could do mad and make it really glottal fry sounding, really crackly, not really something that is comfortable or that we want to hear, but it makes them hear and feel that difference. So if we did mash, mix, most, it doesn't really sound all that great. But then if we have them transition back to mad, mix, most, you can feel and hear that difference. Another thing that I have people do during therapy is actually record themselves. I have them take out their phone, put it face down so it's not on their face, not feeling anxious at all. But I have them just leave it on the table. We hit record. Maybe we'll do 10, 15, 20 words. And then we'll listen back and critique them as we go. Ooh, that one sounded really good. Or, ooh, that one kind of sounded like it was more throaty or back sounding. This has helped significantly with a lot of patients because then they're hearing it in real time. As you move up that hierarchy to phrases, sentences, conversations, you also want to make sure that they're not letting their sentences trail off at the end. That's something we're all guilty of. It's kind of like that glottal fry valley girl sound where our sentences trail off. So if I'm saying, my mom made mashed potatoes, but I let it trail off, it would sound like, my mom made mashed potatoes. And it kind of just falls flat. So you want to make sure they're keeping that sound right at the front of their vocal tract through the whole sentence. Some examples of the oral resonance or open vowel sounds would be like phone, shoe, post, exaggerating your vowel sound to let that voice kind of ring out. That ties right back to the vowel quadrilateral that I showed you at the beginning because the integrity of our voice is found in the vowel. If we let the vowel fall flat, it's going to kind of sound more of that throaty, breathy, strained kind of sound. Then the last part of adding in the resonant voice treatment is to add in the suprasegmentals, playing with intonation, playing with emotions, playing with different ways that you can say things. I always joke with my patients that my voice with them is very different than my voice when I'm at my other job in customer service. I sound a lot more like this when I'm at my other job. That's not our goal. So we always kind of change our voice a little bit depending on our audience and our environment. So sometimes I'll have people practice speaking angrily or speaking with more vocal intensity, but keeping the correct resonance. Any questions on that exercise? Okay. I know we're almost wrapping up here. Can't advance to the next slide. Why isn't it letting me? There we go. All right, so then this part is always a good thing to talk about too. Duration of treatment. How long do we keep our voice patients on for? Of course, we know the answer is never cut and dry. However, if it's a typical, regular, everyday voice patient, vocal fatigue, nodules, polyps, something like that, we're going to keep them an average, according to this study, of 5.32 sessions. When they were looking at this study, they found that it was just enough time to get all of the exercises to the patient, have them make sure that they understand it and that they're performing it correctly, using the right adjustments that they need to in order to make that exercise successful. But they were saying that session durations could range from about 4 sessions to 6.7. And that's looking at 2 different diagnoses as well, presbyophonia versus a vocal fold lesion like a nodule or a cyst or something along those lines. And that's not including some other protocols that we do like LSVT or speak out. That's not including if we're working on myofascial release with that patient. I'm talking your regular cookie cutter voice patient. You can usually get them the information in about 5-6 sessions. After that, it's their turn to kind of really work through those exercises. We're going to do a reeval and see if those objective and subjective measures have improved, stayed the same, or declined, hopefully not declined. So then how do we decide what technique we're going to use? There is a little bit of science to it. There's a little bit of guesswork because like we know, every single person is going to be different. I made this little chart just to help you out a little bit. If your patient has a rough, hoarse, gravelly voice, if there is muscle tension or hyperfunction, glottic insufficiency, and if their voice improves with SOVT, that's your exercise. Same thing with vocal function. If the patient has a hoarse, rough, gravelly voice, if they have muscle tension, glottic insufficiency, vocal fold paresis, and if their voice improves with vocal function exercises, that's your ticket. Same thing with resonant voice therapy. So you're really just going to kind of do the method of throw the spaghetti at the wall and see what sticks in some cases. Other cases might be a little bit straightforward. But that's a decent diagram to kind of guide your thinking. If anybody has access to one of the A-Tempo voice manuals, if you don't, let me know and I can send it to you. There's a wonderful flow chart that Christine Knickerbocker had put together as well. And it's like, if this person does this, go here. Or if it's this person can't do this, go to this exercise. So if you don't have a copy of that, please let me know and I can certainly send it to you. But it gives a nice overview of what exercises are most appropriate. Okay, we're coming to a close here. So we have a case scenario. 42-year-old female kindergarten teacher. She sings in the church choir. She got diagnosed with vocal fold nodules resulting in fatigue and hoarse vocal quality. What exercises are we giving her? Any takers? That's a great answer, Steve. Yes, SOVT. Before that, though, I'm really concerned about vocal hygiene. That's my #1 thing. Knowing that she is a professional voice user, not just any teacher, she's a kindergarten teacher. So she's definitely using her voice a lot throughout the day. She's also singing on weekends at church and practicing throughout the week. So she has a huge amount of vocal demand placed on her every single day. I want to start with vocal hygiene. I want to know what abuses and misuses she might have that she might not even be aware of. I want to find times where she can have vocal naps. I want to find times where she can do exercises. So that's definitely my step one, is figuring out what her vocal hygiene regimen is going to look like. And then after we get that situated, yes, I think SOVT would be fabulous, because not only is it helpful for her nodules and her fatigue, she can then take that exercise with her after those nodules are gone and use it to help her with her singing as well. It's a great kind of bridging exercise for her, especially. Any other thoughts on her case at all before I move on? Okay, awesome. Okay, here are some additional resources. ASHA, we all know and love ASHA. A-Tempo Voice Center is another good one. That's where I was just talking about the flow sheet. That is Christine Knickerbocker. She's located down in Texas, I believe, but her resources are incredible. They're super user-friendly, patient-friendly. They're easy handouts that you can just give to all of your patients. Sometimes she does give some freebies out as well, so I definitely recommend signing up for her email list. There are some great YouTube videos as well. The first one listed, Rejoicing Your Voice. That is Trisha Lyons. She's a vocal coach and a singer. So I primarily use her videos when I'm working with performers. She is phenomenal in every video that she posts. She works a lot on breathing, resonance. She talks a lot about straw phonation as well. She digs into all of the more singing kind of stuff. Versus Melissa Chisholm, she is an SLP. A lot of her videos take place in her office or in the hospital that she works at, and she breaks down all of the exercises that we just talked about. So I do use some of her videos with our typical patients. And then a book that is also really handy if you really want to get into the nitty-gritty of sound science, which not everybody does, and that's okay. It's called The Science of the Singing Voice. It is everything you could ever want to know about how sound waves move through our body, how sound travels through a room. So that's a really cool one to look at as well. And that pretty much wraps us up. Does anybody have any questions for here at the end?
I do have a question.
Yeah.
If anybody does have a question, please feel free to unmute yourself or type it into the chat.
Yeah, please do.
How would I know? I see a lot of patients with chronic facial pain, pain. And some people have some lingual issues, which translate then also into vocal issues. How do I know when the right time is to refer?
Yeah, I feel like you want to ask them, do they feel as though their voice is impacting their daily life? How much is their vocal issue driving negative thoughts? Is it really hard for them to produce a voice? So we give what's called the Vocal Handicap Index, and it goes through how your voice impacts you physically, functionally, and emotionally. So I would ask questions to the patient and say, you know, is it impacting your physical ability? Can you feel like you can get your voice out? Is it impacting your daily life? Is it impacting your mental health? If those are yeses, definitely make the referral. Yeah.
And then also, if I do make a referral, do you need a referral from their family physician or a referral from a PT?
So either is fine. Typically, we would end up getting them into an ear, nose, and throat doctor regardless during the process, because we want to be able to see and know what's going on down there. But yes, a PCP referral is fine, or if they come from PT, that works too. We'll get them into ENT one way or another. Yes.
Anybody else have any other questions?
Thank you again so much for participating and for watching my video. I hope that everyone enjoyed it. I hope that it was helpful. Let me know if you have any questions. Please email me, Teams me, anything. It is not at all.
All right, and also make sure you take the quiz and fill out the course evaluation. And if you have any questions, please feel free to reach out. Thank you very much.